I've been asked to talk about the evolution of the nurse practitioner, and what I'll try to do today is to turn hindsight into foresight, so that some of the experiences and the history will have meaning for you and understanding of change. And it's sort of a saga of change when I look back on it. And with 50 years to look back on, it's quite a history. Of course, I was born in the year that the women got the vote, and we're still struggling to keep it. But we will. And I've lived through that too, though I'm only I'm more than 3/4, 7/8 there yet to celebrate the 100th. Now, if I don't make it, I expect you to celebrate for me. But it's amazing that I haven't been shot so far. So, and there's one way not to get shot: just run faster. It's very hard to hit a running target, so that you can think about that. Now, I would caution you about reading the literature, because some of the things that are published about the early days are myths rather than facts. One of the myths that I'll go into after I tell you what the environment was like a little bit then was that we got into this business, Henry Silver, a pediatrician, and I, because there was a shortage of physicians. That was the first myth. But if you look at the social context in which the nurse practitioner was born, you're looking into a very turbulent time in the 60s. There was social, political, and all kinds of professional changes going on. The political situation, of course, was at the time that Johnson was president, and there was a war on poverty. The civil rights situation, which also raised the rights to health care, vis-a-vis health care privilege. Some of us thought it was a right of the nation to provide that. And then, of course, the Vietnam War was raising many questions and comments and protests. And also in the professions, two of the major concerns at that time was, in nursing particularly, was the 1965 white paper on entry into practice, which the ANA had put out as the new policy orientation for nursing. Well, now, you can't even imagine the brouhaha that raised in the nursing, quote-unquote, profession, because the predominant preparation was through diploma schools, which I'm a product of, and the profession was trying to, elevate the nursing technical, really, education to professional education through academe. But the predominant way for nurses to be prepared as registered nurses was the diploma schools, and they outweighed the baccalaureate schools by generations, of course. So that brouhaha, was festering. In medicine, there was also a great concern because the general practitioners were dwindling for the preparation of specialists. And there were more specialists than there were generalists. About 30% of the physicians prepared at that time were in general health and general medicine, actually. And all the rest were going into specialties. Interesting enough, 50 years later, that has not changed. Anyway, that's sort of a quick review of what was going on in society at the time and the political fights that were predominant in terms of our development. Because nursing was making major changes, not only in the baccalaureate program requirement, but also in the master's. The master's degree at the time was dedicated to functional roles. You went into the master's in nursing for supervision, administration, teaching, but they were not clinical roles. However, some psychiatric nurses had begun to develop clinical roles for nurses at the advanced level. Well, pretty soon the professional nursing group began to look at it in terms of saying, we should have clinical specialists in nursing that are clinical roles and not functional roles. And so we were in the process, we as faculty were in the process of trying to identify what was clinically appropriate for our particular major. Since I was in public health nursing, I was one of the 4 groups that had that challenge in the West. And the challenges were to the med-surg group, to the psych group, to the pediatric group, and to public health nursing. So these 4 groups were working to identify the content. What was so special about public health nursing? What was so special about pediatrics? Were they age-related? Were they, condition-related or whatever? So faculty were busy trying to identify content. Well, if you know anything about faculty, and I don't know if faculty here do the same thing, but at the time, we devised we devised curriculum by faculty getting together and sitting around the table and challenging each other with ideas. When we finally came up with an idea that we thought we all agreed with, we write it down. And the next time we came together, we forgot what it was. Well, we didn't agree, or that wasn't the concept I was talking about. I looked at them, as, well, how shall I put it? I'm trying to put things in ways that are not too truthful. I looked at them as, psychiatrically oriented ossification sessions. Psychologically oriented sessions where we negotiated things and then, of course, conveniently forgot them by the next meeting. So anyway, that's how curriculum was devised. Coming from practice, by the way, and I have been 12 years as a public health nurse in a rural area in Colorado, in the mountains of Colorado, where I was the Lone Ranger. I was it. Whatever went on in health, I was called, I took care of it. Whether it was communicable disease or whatever, school nursing, tuberculosis. I even made inspections in nursing homes as well as running all the clinics and school exams as well. And we had clinics in Crippled Children's Clinic, and we had TB clinics, and we had immunization clinics. But anyway, I was it. So I was used to pretty independent practice, and I knew pretty much what public health nurses needed to know and could learn more. So when I became a faculty member and we had this challenge for clinical content in public health nursing, I said, well, we should have a demonstration project. Something. We did begin to have shortages of physicians who would run our well baby clinics. We ran baby clinics, but sometimes without physicians. But when we had physicians, they did what physicians do, and they did physical exam. We continued to do the education and the growth and development. And so I came to the point where we didn't have physicians. But I looked at it as an opportunity for developing a curriculum that was needed in preparing nurses for taking on that role that was oriented toward health. It was not a clinic to diagnose medical problems, but to define the health status of children and help parents with parenting and do developmental testing and all sorts of things, which we did anyway. And so my reason for that was to say, well, if it works, we'll integrate it into the content areas of public health nursing, into the curriculum. So the fact that the myth came up that it was a shortage of physicians that drove me, it was so anathema to me, because why would I, a public health nursing faculty in the School of Nursing, be concerned because there's physicians, if they should prepare their own. Why should I prepare them? So I said nurses could do that, and we were doing a lot of it anyway. We could do it better, and we'll try it out and see. I thought it was a perfectly good thing to do. As a faculty member, you're supposed to expand the fund of knowledge passed on to students. You're supposed to do research and demonstration projects and collect data and report it and all that sort of thing. So that was my idea, that we would do it and then report to the profession. And so I thought, naively, that I was being a very sharp faculty member. Believe me, I was not. I was not. I was the most unpopular and quickly unpopular faculty member you can imagine, or you can imagine, because I worked with a physician closely. That was out. We were doing physical exams. Now, it was okay to do physical assessment, but you didn't do physical exams. There are lessons in everything I'm telling you today, and I'll give it to you just a little later. So the nursing process, I thought I was doing the nursing process. I thought I was doing independent practice, which I was qualified to do. That's what the profession said I should be doing. They said we should collaborate. We did, without supervision of physicians, which we did. So I thought I was doing exactly as the profession rhetoric printed. That was it. Well, the great trouble was with my colleagues at the faculty, who were very concerned that medicine was going to take over nursing education, that physicians were teaching nurses, that the things that we were teaching were medical techniques. Now, it was okay to have a stethoscope take the blood pressure for the nurse, but if she moved that stethoscope 8 inches, oh, that was medicine. They didn't know what we were doing at 3 a.m. in the hospitals. Believe me, what I did in the hospital when I was a hospital nurse, I closed the drapes in the ward, and I used that stethoscope in lots of places. And at 3 a.m., I mean, I could never figure out who they thought was making all these decisions at 3 a.m. when they wasn't around. Or 9 to 5, everybody was there, that was fine. You saw something, you could call somebody. But at 3 a.m. and you're it, you don't any more than I did in the rural areas in Colorado. So there was, but it was, I was so surprised, naively surprised, because I was a fairly new faculty member too, and I didn't really realize the politics of tenured faculty and the power that they held in. Now the young faculty were all very interested in it. The older faculty weren't. The young physicians were threatened by it. The older physicians thought it was great. If medicine liked it, nursing didn't. If nursing liked it, medicine didn't. So trying to balance all of these things was really quite a challenge. And the only way I did it is that Henry Silver he was excellent in several ways. First of all, he was a wonderful clinical teacher. And I learned a fair amount from him, and he from me. He learned a whole new language that you didn't say physical exam. You said physical assessment. And he had to learn nurse-ese. I knew all the medical terms, of course, but we never used them because we didn't want the physicians to think we were taking over. I used to say that public health nursing was the profession of nursing and public health practiced clandestinely to make the physician think he was the Lord of Health. I didn't say that in public too often. But in a way, that's what we were doing. We had our own language that we used when we talked to physicians, and we were careful to always not cross the line of diagnosis and things like that. So that the faculty worried about the control. Then they worried about the legal aspects. Well, in the legal aspects, what we did, Henry Silver and I, went to the boards. We went to the Board of Medicine. And we didn't go to the Board of Medicine for approval. We went to tell them what we were doing. We went to tell them what we were doing. And then we went to the Board of Nursing. And because I was the president of the Board of Nursing, I reclused myself. But anyway, we also told them, we're not coming to for approval. We're coming to you to tell you what you're doing so you're informed. We also got into publication very early, describing what we were doing in the medical journals and in the nursing journals. And in that sense, we were very transparent. There was no secret about what we were doing. Soon it got all over the place in terms of people wanting to come and visit us and just see for themselves what they, and so we really ended up organizing the visitors to come for a conference one whole day so they could learn about it. The students were phenomenal. They were all very highly qualified students, and they were articulate, they were mature, they came from practice, and they were able then to articulate what they were doing in terms of visitors, and the first student we had even had an article, even was featured in Time magazine for this new role in nursing. And so, and we talked about the role in nursing, that the goals were health goals. They were not goals to diagnose diseases, but to diagnose health status. They were oriented toward education of mothers and children, and pretty soon it got pretty difficult for others to oppose us. And so then finally, of course, we began to have funding from the government, from the Commonwealth Foundation, and evaluation of the program. We got money for that. So that it was a movement that kept, really taking on. And we had some constraints in terms of what the students were going to do when they had 4 months of theory and about 8 months of practice in the field. And most of them were in either health departments or specialty clinics or schools or whatever, because then we began to have school nurses, and they began to take everything else. But if we had waited for Colorado to move that to the master's program, we were really disappointed, because we had about a 4-year project, produced about 64 nurses, and were highly enthusiastic about it and speaking about it and going around not only visiting but demonstrating what they could do and how they could do it. And I was invited to speak in many places, so there was a lot of national interest in it. And other people were doing some things too. Rochester soon had a continuing education program, and people took it up. The VA started to prepare their own, the military began to prepare their own, and they were all continuing education programs, because the agencies could not wait for the universities, the university faculties, to move to preparing people at the master's level. And it was a very tumultuous time. It was difficult for me personally, because I had been a relatively popular faculty member, been well known to the faculty and everything, and all of a sudden I was isolated. Nobody would talk to me. They would close their doors so I wouldn't visit with them. And it was a kind of bullying. If you look at it as bullying today, it would be bullying, because there was a lot of backstabbing and gossip about it, and we were kowtowing to medicine and doing medicine's work, scut work that they didn't want to do, and all sorts of things. And so, but I did a lot of self-searching. Johnson said that adversity is the best time to get to know yourself, because you have so few admirers at the time. So I did a lot of soul searching in terms of whether I wanted to stay in nursing. I had many opportunities to go to schools of nursing or to go to other schools of nursing and everything. But I believed in it, and the students were the ones that convinced me that this was something they wanted. They were enthusiastic about it. They were professionals in their efforts, and they too learned to write about their experiences, and they were my saviors, really, because if it hadn't been for the students, I doubt I'd be here talking to you today. And other people began to see this as a vital thing, and teams of physicians and nurses began to try things out in adult education and things. They were all CE programs. But those CE programs were the savior of the whole movement, because they kept the interest and the movement going the VA did, the military did, and Planned Parenthood even did. Now, they did it for their services mostly, and that was fine, but it did specialize them a little bit. They also did not maintain academic standards. To a certain extent, those nurses who were very excellent nurses, most of them were diploma nurses, still made a tremendous contribution to the survival of this role, because it took the universities a few years to get off their duff, the faculty members, and begin to train faculty to teach in these programs and develop them. And they were helped by the Robert Wood Johnson Foundation, because we got them to put on a teacher training program and provided ways for faculty to become qualified to teach and to organize and run nurse practitioner programs. But it wouldn't have survived without those programs. And unfortunately, as I say, the nurses that were in them were exploited once again because they didn't have the academic credentials. So when they tried to run to accreditation, stuff like that, accreditation began to, bring in certification and accreditation of programs and things like that. They were they didn't qualify academically for that. And sometimes the schools were not as responsive to taking them on. And Colorado was not one of the early schools to do it. Henry Silver and I got a letter from the dean that said they could not support our continuance. So that drove me to Rochester, who was ready to do some very innovative things, including the nurse practitioner, which in Rochester became quite famous for that, and the unification model, which went together. Because it was obvious that there are many faculty who were not practicing and who were clinically incompetent to practice, but were teaching students. Well, my view on that was these should go together, that faculty who are in practice can find the seminal problems that need to be researched. So they ought to be able to use practice integrated into the research efforts and try to begin to make the research relevant to the practice, which was needed very badly. And also that their competency gave them a lot of flexibility, a lot of options that they didn't have before. And it gave them not only research material, but publication material. And once they got onto the idea that this was a very useful thing, we're seeing a lot more publications come out from faculty on very different areas of specialization, and they made a real contribution. But it took them a little while to get over the fact that we were working so closely with physicians and stuff like that. So, and physicians had a lot to learn about the professional nurse and to recognize some of their competencies as well. So, but Henry Silver did not have the resistance that I experienced in terms of insisting that it comes in. Well, there are lots to be learned from history, and if you learn it well, or listen to it, or think about it in relation to today, you'll learn some things that you might find useful. One of them was, your mother always told you, watch your language. Although she said, watch your mouth, right? You ever hear your mother say that? Oh, you're too young. But believe me, language is very important about what you call things, because we had a great deal of problem in the beginning, being separated from the physician assistant, which was also a program, which was, do any faculty remember Thelma Inglis? Thelma Inglis, too young. Anyway, Thelma Inglis worked with Gene Stead at Duke University. And Duke University and Thelma Inglis, who was a very well-known nurse at the time, and did a lot of international work for the Rockefeller Foundation, and she and Gene Stead, who was the father, so to speak, of the physician assistant movement, worked together, and they tried to use nurses as in some of the same kinds of things we were doing. But they made, I think, a big mistake in terms of calling it for physician assistant, because that didn't go over well at all. The accreditation agency said, no way are we going to accredit professional nurses to be physician assistant. Because the old handmaiden, we were trying to get away from being a handmaiden to physicians and wanting independent practice or autonomy, and so there were very few people who would support that. On the other hand, that's how the physician assistant came into being, because the accreditation agencies in nursing would not allow the Thelma Ingalls and Eugene Stead to have their program accredited. But they had many of the elements that we wanted, was a master's degree integration and you know, assessment and all that. But so language is important. Language matters, what you call things. And if you use the words medicine in terms of what you're trying to do in nursing, it will never be an acceptable kind of an idea. Because our role is not to be a substitute or delegatory to medicine. We're our own profession, and we carry with it certain kinds of things. Now, that doesn't mean that we don't sometimes use the same tools, even with the PA, or that we don't use the same language in terms of some of the diagnostic things today. But it does mean that if you start calling nurses physicians extenders, how would you like to be a hamburger helper? A physician assistant, physician associate, physician this or physician that is highly unacceptable. And we never use those terms, never. Also, now today you can say physical exam, but then you couldn't say physical exam, which I explained earlier, or any of the diagnostic terms that medicine held unto itself. Now, the AMA has always loved the nurse practitioner if it is controlled by medicine. But they do not accept, I don't like to call it independent practice. There's no independent practice of anybody. Autonomy in your own profession is a more acceptable thing. Because everybody is interdependent in some way. The physician is interdependent on nurses in terms of quote unquote, in earlier years, carrying out his orders. He's interdependent. We have to depend on each other. This is also true in teamwork. We know more about teamwork than anybody else does, and now it's just been discovered. Just like population health. We know more about population health, but now nursing is beginning to talk about population health. Never did before. It was always a denominator in terms of my work in public health. But now they just discovered it. I can remember being at a meeting in Seattle one time, early, and this was a bill that psychiatric nursing is announcing a big new deal, new role, new something. So I said, boy, I'll go to that session. Well, I went to the session. It was loaded with people. I'm sitting in the back row. So I'm waiting for them to announce what's going to be this new role for psychiatric nursing. Psychiatric nursing was going into the community. I jumped up and I said, oh, for God's sake. I was so embarrassed. It shocked me. They just discovered the community. We're here in the community. So it's just amazing, what goes around comes around, and what's new is never really new to somebody. But there are lessons to be learned from history, and there are lessons that you need to think about now. What about the future? I think there are several things in the future that we're really going to have to, I'd like to see us take advantage of, because I think they're good. The genomic codes are really going to be a real part of practice, education, and research. There's no getting around to it. Precision medicine is now coming in, right? We've had precision nursing for a long time. But now they've discovered that individuals are different from each other. The other thing is that all this technology that's coming in, I have to get a drink, talking too much. Am I about out? Just a minute.
2 minutes.
Okay, 2 minutes. All the technology that's coming out is going to do away with all the kinds of things we're spending a lot of time on learning. And who's going to be in charge? The patients. Are you familiar with Topol's work? Have any of you read Eric Topol's work? You've got to read it. He's a cardiologist from Scripps, and he's done a lot of work in computerization to collect physiological and psychological data by sensors. And these sensors put on patients all over you are going to provide the patient with all this information about everything from blood pressure to glaucoma pressure, from EKGs or ECGs. Everything you want to think of is being censored. He hasn't used a stethoscope in 3 years. Doesn't need it. The patients are censored. But who gets the information first? The patient. And he has to decide what to do with it. Right? What does that tell you? He needs to be pretty smart, and he needs to have a computer so he can look it up. So he can look up what's going on and seek out sources of information and consultation. You'll be on the list for that patient to call you and say, my blood pressure is doing this, my INR is this. Everything you can think of is going to be censored in the body in terms of giving information. Eric Topol's work, the first one was the creative destruction of medicine. The creative destruction of medicine. The second book is called The Patient Will See You Now. The patient will see you now. He will determine whether or not he needs to go to your office. his work is very interesting because he's predicting what's going to happen in some of the institutions as well. So I think we're going to see some huge changes in the future. And I think as prepared as nurses are becoming today, they need to think about some ways to get newly prepared. So, yeah, now's the time. I'm not quite finished, but I will take some questions that, and Nancy may be repeating them if you don't speak loudly enough. But if you speak loudly enough, she and I can hear them between us.
Cynthia?
I wanted to ask about your views of the development of the Doctor of Nursing Practice.
The Doctor of Nursing Practice, to me, is a natural evolution. And we're the last profession, I think, or next to the last profession, who's going to use the Doctor of Nursing Practice, a Doctor of Practice, as a professional degree given by the universities, and that earns you a doctorate in nursing. The audiologists have it, the pharmacists have it, the social worker, I don't know about the social worker.
Physical therapist.
Physical therapy, medicine's had it for a long time. So, and it came about because nurse practitioners themselves wanted advanced education beyond the master's, but not the PhD. They didn't realize, frankly, that the research, because the PhD was supposedly purely research, they did not want to leave practice. But what the DNP is going to be into is translational research, working with PhDs in terms of clinical problems. They're the ones that are going to identify the important clinical problems, and those clinical problems are considerable. And if they can work with PhDs on the methodologies, collection, the sentimentology that they really need to, they will find an exciting one. And I think we're going to see a lot of DNP PhDs. We'll end up with that. It's like the MD PhD, right? Or the Pharm PhD, for people who were really interested in the practice. And the reasons a lot of people got into NPs is because they were disgusted with nursing practice or unhappy with it or something. And so they're finding that the nurse practitioner or the advanced practice nursing roles were more exciting, more challenging intellectually, and that it just comes naturally. So I think that, of course, there's a lack of enthusiasm for some MPs in terms of the DNP. But they forgot they had asked for it. Just be careful what you ask for, you might get it. Right? You know what we're saying?
We're out of time for questions, but Donna, would you dim the lights? I think, Lee, you wanted to ask the audience for some input.
Okay, I want all of you to close your eyes. Don't cheat. Close your eyes and think about what the future, your future, is going to be like. Not my future, not Susie's future next to you, your future. Think about that in terms of where you are, where you want to be, maybe 5 years, maybe 10, how you're going to get there, and what kinds of things it's going to take. And I don't want any of this yes, but. I want you to think about that. My shirt. I want you to think about that very seriously, because we don't spend enough time dreaming about it. Now, you got a bucket list, and it's a mile long. And start putting these things on your bucket list. And when you finish, you'll probably end up like this. Super nose. You know, I have been credited and crucified. I've been reviled and revered. I've been kicked and kissed. But I haven't been Botoxed or detoxed. Thank you very much.